Fascicular blocks, conduction, pathology. The clinical translation arc. Mastering conduction pathology requires linking mechanistic why to clinical how. Anatomical vulnerability, understanding the His-Purkinje structure and ischemic risk. ECG recognition, identifying single bifascicular and trifascicular patterns. And then the last, guideline directed medical or device management with acute intervention and permanent pacing decisions. His-Purkinje conduction circuit. The bundle of His acts as the central conduction highway before bifurcating into three specialized lanes. Blocking single or multiple paths create specific, predictable downstream conduction delays. Right bundle branch block because it is involved in the supplying of right ventricle and septum. Left anterior fascicle routes to the anterior and lateral left ventricle, and left posterior fascicle routes to the posterior and inferior LV. A right bundle branch supplies to the right ventricle and is involved in the septal activation. The ischemic vulnerability model. A fascicle's vulnerability to block is directly proportional to its vascular redundancy. Single supply, high risk, thin, long, left anterior fascicle and the right bundle branch rely almost exclusively on the left anterior descending coronary artery. Anti-AMI readily obliterate these pathways. In dual supply, low risk, thick, short, left posterior fascicle possessing robust dual supply both from LAD and RCA, and its isolated block is therefore exceptionally rare and indicates any severe diffuse underlying pathology. So left anterior fascicle is thin and long, posterior fascicle thick, short and broad, right bundle branch is distinct main branch. Left anterior fascicle is supplied by LAD, left posterior fascicle is supplied by LAD and RCA or PDA, posterior descending coronary artery, and right bundle branch is supplied primarily by LAD and variably by right coronary artery. Ischemic vulnerability of left anterior fascicle is the highest, right bundle branch is moderate to high, while for left posterior fascicle ischemic vulnerability is low. Pathology is most common in left anterior fascicle, common in right bundle branch, but rare in left posterior fascicle. What are the pathophysiological drivers of fascicular block? First and foremost, ischemic or vascular injury due to coronary artery disease, anterior MI, hypertension. Degenerative or structural problems like Levy-Lineker disease, degenerative fibrosis, cardiomyopathy in congenital heart. Infiltrative and inflammatory causes like myocarditis, sarcoidosis, amyloidosis, and iatrogenic during cardiac surgery and transcatheter aortic valve implantation or replacement. Vector mechanics and axis deviation. When a fascicle blocks, the vector is physically pulled towards healthy unblocked tissue first, followed by the delayed activation of the blocked territory. So in LAFB, the mechanics are that depolarization vectors shift superiorly and left towards the blocked territory as it depolarizes late, resulting in left axis minus 45 to minus 90 degree deviation. While left posterior fascicular block is depolarization vector shifting inferiorly and rightward, resulting in right axis deviation plus 90 to plus 180 degree, as shown on the hexaaxial axis wheel. Left anterior fascicular block diagnostic criteria is that it is the most common. QRS duration is less than 120 millisecond if it is isolated, and small q, big R complexes in high lateral 1 and AVL leads, while small r, big S in 2, 3 and AVF. So LAFB is left L for left axis deviation minus 45 to minus 90, E exclude inferior MI and LV hypertrophy, F is front fascicle, it is anterior fascicle, and T it is thin fascicle with thin supply of blood, that is single blood supply. Mandatory exclusion for LFB diagnosis include other problems as well. Because left axis deviation is not only caused by LFB, you should look for inferior MI, which may have deep Q waves in 2, 3 and AVF. It may mimic leftward axis deviation. Left ventricular hypertrophy, increased muscle mass, independently alters the depolarization vector, and ventricular pacing, naturally generating left or bizarre axis deviations. Loss of inferior forces will mimic left anterior fascicular block. Left posterior fascicular block. Diagnostic criteria is an exceedingly rare thing. QRS is usually less than 120 milliseconds. Small r big S in 1 AVL, small q big R in 2-3 AVF. P is points right axis deviation plus 92 plus 180. O is often rare. S is short and thick fascicle and stable and safe because it has T2 blood supplies. Mandatory exclusion for LPFB diagnosis because LPF is robustly protected by dual blood supply. True isolated LPFB is a diagnosis of exclusion. RV hypertrophy, thickened right ventricle, lateral MI, pulmonary hypertension, acute chronic with right heart strain, and vertical heart variants. Normal variant in individuals are mandatory exclusion for left posterior fascicle diagnosis. The conduction block diagnostic matrix LAFB, axis deviation is left, LPFB, axis deviation is right bundle branch block, normal unless bifascicular. QRS duration is less than 120 for both fascicular blocks, but more than 120 milliseconds are equal in right bundle branch block. Small q big R pattern 1 AVL in LAFB, small r big S pattern in LPFB, and broad terminal S wave in right bundle branch block. 2-3 AVF, small r big S pattern in LFB, small q big R pattern in LPFB, and there is no such thing in right bundle branch block. Bifascicular block, both closed. Bifascicular block is a widespread conduction system disease heavily reliant on the single remaining pathway to activate the ventricles. So most common is right bundle with left anterior fascicular block. Both share the LAD supply. Anterior ischemia readily obliterates both pathways. Less common is right bundle branch block with left posterior fascicular block. Rare and high risk is both LAFB and LPFB, and this will progress to complete AV block. Think syncope equal to intermittent complete heart block until proven otherwise. Trifascicular pattern versus true complete heart block. The clinical illusion of right bundle with left anterior fascicle and first degree AV block. A prolonged PR interval does not definitely prove disease in the third fascicle. The delay is most often frequently isolated to the AV node, as shown in the diagram. True extensive conduction disease is alternating right and left bundle branch block, unequivocally demonstrating bilateral severe His-Purkinje system failure, an ominous predictor of sudden complete heart block. So benign versus impending failure fascicular block is identified, usually benign with no emergency management in isolated LAFB, chronic stable fascicular block, isolated right bundle branch block in asymptomatic individuals without structural disease, and high concern require acute workup in syncope or presyncope, new bifascicular block, alternating bundle branch block, chest pain or acute MI, and white QRS presenting with bradycardia. The acute emergency department evaluation is always for general stability and all the circulation and hemodynamics. After that, early ECG with continuous telemetry. If some blocks are suspected, IV access is paramount importance. Then there is comprehensive history, especially medication review with electrolytes and troponin testing, and echocardiography for structural heart disease, infiltrative problems, and myocarditis, etc. Continuous monitoring is mandatory for syncope, high-grade blocks. Interrogating the block, new versus old. Old bundle branch block, previous ECG will show the similar pattern, and it is chronic and stable with standard baseline care. New bundle branch block, no prior ECGs available or documented, and always demand aggressive investigation to rule out acute MI, acute myocarditis, new onset cardiomyopathy, and rapidly progressive degenerative conduction disorders. Ischemia in LBBB by Garbosa, modified Garbosa criteria. Concordant STE more than 1 mm in any lead. Concordant ST depression more than 1 mm in V1 to V3, and proportionally excessive discordant ST elevation with ST to S ratio less than or equal to minus 0.25. This is modified Garbosa criteria for diagnosing ischemia in LBBB. Special scenario, new right bundle branch block plus LAFB and anterior MI. The emergence is a catastrophic prognostic indicator, suggests massive extensive septal necrosis involving proximal His-Purkinje system, proximal LAD occlusion, exceedingly high risk, may abruptly become complete block, refractory cardiogenic shock, and mortality is very high. Management mandate is admission, rigorous monitoring, prophylactic temporary pacing, and urgent EP intervention. So, whenever you see these red flags, you should immediately go for high intensity coronary care unit care, new onset BFB, alternating bundle branch block, any fascicular block with syncope or presyncope, fascicular block complicating acute MI, high grade AV block or complete heart block, and should look for any necessity of immediate temporary pacing. And that's all. Thank you very much. Thanks for listening. This is Dr. Asifullah from KMU IMS KDA Cohort. Stay tuned for further insights into cardiorespiratory modules.